next slot is Adam Gray. He has called his session "A Kid Doctor in the Emergency Department." So, apparently you don't grow up in medical.
Hi, I'm Adam. I worked for Muller last year, which was fun. I was in Brighton. I've now moved up to London, and I spent the first 6 months of this year working in A&E. And I don't know how many of you have worked in A&E or have probably been there before with your broken child or arm. And I know Drew comics before, and I don't really understand any of this academic stuff that we'll talk about later. But anyway, it's just some of my thoughts. And when you work in A&E, it's all rather exciting. You see lots of things that you've never seen before. You're quite sheltered down here in Brighton. It's all very pleasant, but Croydon Hospital is well, it's rough, isn't it? But again, I was finding all there's lots of new medical stuff that I was coming across. There's also actually, when you started thinking about it, there's quite a lot of ethical issues that I hadn't really thought I was going to come across. And I drew this one in the end. So this is where I work, or sort of how it feels sometimes. So this is me. I also have an orange stethoscope. I can't read your faces or anything, but which is why it's all a bit. But yeah, that's where I work, and that's how it feels like, and it's a really stressful department. I think I saw 1,300 patients or something. I don't know if that's a really meaningful number. It just felt like masses. And you don't really have time to process it at the time because it's all just a bit quick. So this is one of the first things I learnt, or saw I suppose, was cardiac arrests. And it's very hands-on in Croydon. And so this is a young guy who came in, and I've got no idea what was wrong with him. He came in, his heart stopped. And you know, you're not emotionally engaged with these. You're standing there and you're doing what you need to do, do chest compressions and this and that, and you give them a shock if they need a shock, and you give them this and that. And he died, which is a shame. And the consultant, and it's very macho. It's very, very macho. But you take it home with you, and you're sort of told you're not meant to take these things home with you. You're told you're meant to leave your work at home, leave your work at work. But inevitably you don't. You do take it home. Is that the right thing to do? I know my consultant is. This is my consultant. So this is after another arrest call, which is harrowing actually. So this is a much older lady who was always going to die in retrospect, but her whole family were there, and towards the end of the resuscitation they were all screaming, holding her hand, saying don't stop, don't stop. I've just started this job and there's about 3 of us doing this. Anyway, so he's afterwards, we all have this debrief, and he said, you can't engage emotionally, because if you stand there and you cry when the family's crying, you're not going to defibrillate when you need to defibrillate. You're just not. And so you have to just put on that sort of cold shoulder, cold face, and that's what makes us good at what we do. I was like, well, do what? I do like needles and drugs, I do like that sort of thing. But that's sort of part of it, and I said, well, what about all this other stuff that we learned about in med school, and you're being caring, and trying to understand what the patient wants, and talk to the family, blah, blah, blah. But you really had to, especially in A&E, it felt like you just had to put that to one side. So it wasn't important. It wasn't what you were there to do. You were there to provide a service, and there were lots and lots of people. And this is saying, don't worry, you'll learn. So I do worry about that, actually. And I hope I don't learn that, because I sort of got this fear that that would sort of drift into the rest of your life, and all of us, anyway. This is another one that's made me laugh. Sorry, I swear sometimes, I do apologise. So that's a broken hip, if you don't know what a broken hip looks like. So this is Doris in the emergency department, and they come in, and broken hips are dead easy in A&E. They come in, they have the x-ray almost before you see them, and you go, that's a broken hip, you go to orthopaedics. This is Doris, she's 80 or whatever, I don't know. You see, I'm normally very good on my feet, and this morning I was just at the front door chatting to Harry, he's my neighbour, and I've been having this back pain for a while, and you're like, Doris, fuck off. Like, and okay, I never actually say this in real life. But you've asked them what happened this morning. She goes off on this rant, and you're like, I don't care, I already know what the problem is. It's really not my problem what you tripped on, and it doesn't make any difference. I'm going to give you pain relief, I'm going to give you oxygen, I'm going to do an ECG, I'm going to refer you to orthopaedics, and they're going to operate on you tomorrow morning. And all that other stuff doesn't matter. It doesn't. And so obviously in my head I'm going, oh, that's a very nice story, thank you, Doris. How's Harry? And my boss is sort of standing at the edge going, we've got like a 4-hour waiting time. So I'm not sure I've really resolved what I think the right thing to do in that scenario. So I think it's somewhere in the middle, and you do have to be brief. Is that the right thing to do? This is sort of similar. So whereas in the last one, that's definitely, if I turned around and told Doris to fuck off, that's definitely my fault. That's me being unethical. This one, I thought, was my thoughts really on how the system's slightly unethical at the moment. There's a BMJ survey said last year saying our Kew Hospital's the right place for frail and old people. There's a survey of people that read the BMJ, so it's largely doctors and consultants. Normally it's like 60% against 40%. That was pretty strong. And so this is Doris, sort of, not Doris, and they're not Doris. Who am I, why am I here, sort of asking sort of deep and wonderful questions, and whose clothes are these, and why is this bed wet, and just better go and find out. And that's me saying, get back in bed. Because we're walking up and down, we know the department, and we know that lady in bed 9 keeps on trying to get out of bed, and no, get back in bed, you'll be fine, and you don't have the time to engage with that. You don't. And the nurses don't have the time to engage with that. You just don't. And I think that's a fault in the system, and no one really knows how to solve that yet, which is a shame. Here's another song sort of hammering through. This is an ambulance. The tricyclics are a type of antidepressant. Probably slightly less now, and they don't come in feigning unconsciousness anymore, but TCAs are they're still a bit in vogue if you want to try and kill yourself. So that's LAS, London Ambulance Service. So he's come and he's saying it's 10 o'clock or whatever. Found this lady and she's taken all these tablets with a bit of alcohol and she's left a note, and it's amitriptyline, and amitriptyline is quite exciting because it does all sorts of stuff to do breathing, your heart rate and your rhythms, and you're unconscious. And so it's quite exciting from a medical point of view, and they're quite sick. They come in like as a blue call, so an ambulance and phone up and you have to get ready for them, and then they arrive and the patient's not breathing, or they're not breathing very fast, and it's an emergency. It is an emergency. So then this is me, you do this shoulder squeezing, squeeze them as hard as you can. She doesn't open her eyes, and so this is putting on some oxygen. You give her some fluids or some bicarb, and you keep on checking ECGs just to see whether the rhythm of the heart is like resolving slowly. And it takes hours, and it's quite intensive. And certainly for some of these patients, you're always on the sort of borderlines. Does she need to go to HDU? Is she going to be okay? Inevitably, they usually pull through, and eventually, after enough stuff, they start to wake up. And this happened 2 mornings in a row, actually. It was about 3 in the morning when they came in. And then sort of 7 in the morning, I was clocking off. And I see her wandering out, going out the fag. Like, you staying for like your psychiatric assessment and stuff? She's like, no. You're like, ah. And then it happened the day afterwards as well. Got a call in saying, overdose, unconscious. And everyone's like, oh yeah, you can go do that one again. You know what you're doing. It's probably the same person. And it wasn't, but it might as well have been. And you do this thing, that took, I don't know, 3 hours of my time, which is too long. In the night time there's horrific queues, and you don't know who's in the queue, you don't know how sick they are. And so I suppose one of the thoughts on that is, can I judge, or should I judge her choices? Am I allowed to judge her choices if they are putting her at risk? I'd argue probably not, because we all make choices that put ourselves at risk, and so that's very easy. But then you say, well, look, not only are her choices putting herself at risk, they're also putting lots of other people at risk, because the service is under restraint. And so, does that become ethically wrong on her part? I don't think it does, but I don't know, if someone convincing told me it did, then I'd probably believe them. But this is a sad story. I didn't see this kid to start off with, but anyway, so 7-year-old child comes down here, he's got what looks like a cold, bit of a headache and a fever. Very boring. And he said, probably just a cold, go take some paracetamol ibuprofen and go home. And then he comes back later with this horrific rash, and he's got meningitis. So everyone sort of craps their pants a bit. And inotropes is clever, light, hardcore drugs, and he goes to ITU and he gets intubated. And he dies about 24 hours later, which is very sad. Obviously, that's sort of meant to be his parents, and that's sort of doctors looking in the mirror thinking. And the entire paediatric department were absolutely shaken. And the kid, the team, every single one of the team that had sent him home first time, just went home and cried. They did, and it reverberated throughout the whole hospital. It was awful. And then fact of the matter is, you'll see almost the same presentation the next day. And then, deep down, you know that you have to send him home again, because we run on evidence-based medicine, and you can't let one horrific event change. Okay, so you're more vigilant, but you can't LP every child that comes into the department, because that would be manifesting it. It's not what we're meant to do. But this happens in different formations often enough to, and you really need to step back and think, well, and just make sure that you are still maintaining good patient care and that you're not emotionally driven, so to speak. It's difficult when you're faced with crap like that. And this is a sort of similar one. I drew this fairly early on, sort of after working with Mona in it. I suppose I was feeling a bit fatalist. I don't know whether that's the thing. There's another broken hip. Let's call him Harry. And he's on the ward, and then he gets a cough, and he's got a hospital-acquired chest infection. And they don't all die, but a lot of them do. And that's sort of the oxygen. He needs more and more oxygen, and eventually he dies, and we chuck that on the floor because you don't need it anymore. And I think the thing, after I drew that and I looked back at that recently, I thought, I don't think being a fatalist is a particularly good idea if you're a doctor. So, yeah, that's my only thought on that, really. But I think I suspect there's a little bit in most people that kind of are. There is an inevitability in A&E that you see something and you know what's going to happen to it. But I think that's a dangerous path. I've got one more, and this one made me laugh. There's an ambulance again, and there's pads on. We see a lot of cardiac arrests, and I quite like them, so I tend to go to them. And this was quite a good story. It's about 3 in the morning again, and the registrar, I'm only a second year doctor, but the sort of more senior doctor overnight is having tea or something, I don't know. And so we get a call in that there's a VT, which is a funny heart rhythm. It's quite a dangerous one. And he comes into the resuscitation department, and he's sitting up on the bed with the ambulance staff, still in this rhythm. And then as we're sort of almost about to transfer him, he goes into VF, which is basically, you can't have a pulse with VF. So that means he's dead, so he goes. And there's 2 nurses, a couple of paramedics and me. And it all went swimmingly, actually, which was nice, because he could have died, but he didn't. So we defibrillated him, and then he woke up, and he had a pulse. And then it's, oh, that's ace, wasn't it? Like, first life saved. It's like truly in front of me, and that was fantastic. It's a high five. And no one gave me a high five on me. Just an amiodarone is like the clever drug that you use to treat these rhythms, so we probably should have given him some of that instead, and we did, obviously. One other thing that I thought about this one was, I don't even give that title up in mind. Was why was I so pleased at that? And we've all been in similar scenarios to that. Why was I so happy about that? Was I happy because he came back to life? No, not really. I mean, for the sort of few minutes that I did know him and speak to him, he was a big, fat, smoking, belligerent man. No, he was. I didn't know who he was. So and you don't really care about strangers, not really, not emotionally. But I did feel great, and I felt great because his rhythm changed from a naughty one to a good one, and that was great. And that was success, and that was 5 years of medical training and winning over chance or heart attack or whatever he had. I don't know, I thought that was an interesting idea, and why do I do what I do? What aspect of my work do I gain enjoyment from? And is that good, or is that right? I don't know. Anyway, that's all of them. Thanks.
Thank you.